Hello everyone, this is a results presentation for Work Package 1, and the purpose of Work Package 1 was to develop a new care pathway for older patients with multimorbidity and cancer. This was a joint project for 3 countries. In the Netherlands, the Diakonessenhuis, myself, Marije Hamaker, I'm a geriatrician, as well as Nelleke Zegers, who is a PhD student. In Norway, Oslo University Hospital with Siri Rostoft, who is also a geriatrician, and in Ireland, Shane O'Hanlon on behalf of University College Dublin, a geriatrician as well. But we also had help from many others, both healthcare professionals and patients, who provided us with their expertise and their experience. So what is a care pathway? A care pathway is a structured multidisciplinary plan that maps out the sequence and the timing of care for a patient with a specific care need or illness. And multimorbidity, what we are focusing on in Geronte, is the coexistence of 2 or more long-term health conditions at the same individual at the same time. And this can be physical illnesses, mental health issues, as well as chronic impairments. So why do we need a new care pathway? Well, currently medical care is fragmented between a range of medical specialists who focus on only one component of the patient, for example, their heart or their mobility issues. Similarly, care pathways often focus on only one disease. But as people age, they will accumulate a range of illnesses that may affect their ability to tolerate treatment, their remaining life expectancy, as well as their wishes and priorities. And these aspects are often not taken into account in a single disease care pathway. And patients then run the risk of either undertreatment, not receiving a treatment that could be beneficial to them, because a cancer specialist, for example, is unsure how to proceed in light of the other comorbidities, as well as overtreatment, a patient receiving a treatment that's too burdensome for them because the guideline is followed without taking the comorbidities into account. So at the onset of the work package, we thought about what questions we wanted to answer. And the most important thing was to get a good grip on what issues the new care pathway should aim to resolve. What's important to patients and their caregivers that we address? Who should be involved in the new care pathway? And what information is needed at each step along the way? And how can we empower patients for self-management? So let's look at the first question. What issues should the new care pathway resolve? To address this, we did questionnaires and performed interviews with 36 healthcare professionals, as well as 12 patients and/or their caregivers. And these were the main issues that were highlighted. First of all, how to choose the best treatment when we know that there is only limited evidence that can support such treatment decisions. Most of what we know about cancer treatment comes from studies that were done in patients who were younger, more fit, and without chronic conditions. So what do you do when you are treating a patient that is older, may have functional impairments and other diseases that are limiting their capacity to tolerate treatment? How do we handle the interactions between the cancer treatment and other diseases, and how can we catch complications at an early stage so that an early intervention may prevent permanent deterioration of the patient's health status? How can we coordinate care to avoid fragmentation? And how can we support patients to deal with symptoms of the disease or of the treatment? And how can we help them to maintain their functioning and quality of life? And we also looked in more detail at what's important to patients and their caregivers in the decision-making process. We looked at their information needs, the roles that they wanted to take in decision-making themselves, as well as the role that they wanted their caregiver to have, and how they prioritized different outcomes. For example, extending their life expectancy, maintaining their independence, treating symptoms of the disease, and avoiding side effects of treatment. What we found was that the priorities, their wishes and their needs were highly individual and personal, and so we couldn't create a one-size-fits-all. Instead, what we did was to include 2 tools in the new care pathway that allow the patients to express their preferences. One is an outcome prioritization tool, and the other is a decision control tool, which allows them to express how they want decisions to be made. Do they want to make it all by themselves? Do they want a doctor to make the decision for them? Or is it something in between? Then we looked at who should be involved. The first thing we tried to do was to develop patient profiles. Maybe we could group together patients on the basis of their similarities so that we could develop a standard pathway for them. But we found that despite the similarities, there was still a lot of variation. And so we couldn't make a one-size-fits-all. Instead, what we did was we developed the Healthcare Professional Consortium. This is the core group of people that should be involved at every step along the way in the decision-making and the treatment trajectory for the patient. This core consists of a cancer specialist with all their expertise of the specific cancer that the patient is dealing with, a geriatrician who can focus on all the other issues that the patient may have, an advanced practice nurse, the first point of contact for the patient, a kind of case manager who also takes care of the coordination of care between the various different people who are involved, the primary care physician, and any other medical or paramedical specialist that may need to be involved. The HPC should come together in structured meetings prior to decision making and at every 3-month interval to assess the patient situation, also allowing the patient to reassess their priorities and preferences. And for this, we made a standardized list of questions that the HPC should discuss together and answer prior to making treatment decisions. And also to assess the need to change the original plan or perhaps implement another intervention, for example, a physiotherapist or some home health care to optimize outcomes, functioning, and quality of life. Next, we looked at what information is needed. And we developed a core data set for decision making, which includes oncologic data, all the information about the cancer that's relevant, medical data on comorbidities, not just providing a list of which other diseases are present, but also an indication of how severe they are. Perhaps there are specific measures that can be used to quantify the severity, how much they impact the patient's functioning and their quality of life, and what medication the patient uses. In addition, we provided information on the overall functioning, for example, their physical functioning and care dependence, their mobility, their locomotor function, sensory functioning, how is their hearing and their vision, what's their nutritional status, how is their cognitive function, their mental capacities, any mental health issues, is there sufficient social support, and what does their social environment look like? And for each of these domains, we provided an assessment guideline because not all healthcare professionals will be familiar with assessing these domains, as well as an intervention protocol with suggestions of how to support a patient that's dealing with these issues. Together with My Patient Space, which is work package 2, we developed a dashboard for the healthcare professionals where all this information was integrated in a comprehensive overview. And here you can see a projection of this dashboard as it's being used by an HPC. The next question we looked at was how to improve early signaling of complications. And if the health status of a patient is complicated with multimorbidity and cancer, complications can come from various reasons. They can be related to the cancer or the cancer treatment. They can be caused by destabilization of one of the other conditions that the patient have. There can be no specific symptoms, but just a general loss of functioning or loss of quality of life. And all of these issues are important to catch as early as possible. What we did was to develop a list of daily, weekly, and monthly symptoms that should be monitored during the treatment trajectory and follow-up. And this was integrated in the form of a newly developed patient application. And one of the important things was that we included warnings to the patients that if their symptoms had a certain level of severity or were alarming, that they should contact their health care providers to get immediate medical care. And here you can see some screenshots from the patient app. And as you can see, it's developed for mobile devices such as a smartphone or a tablet. The information of the patient application and the symptom monitoring is fed back to the healthcare professional dashboard so that the APN and anybody else who is involved in the patient care can follow how these symptoms or issues develop over time. To empower the patient for self-management, we realized that some symptoms and complications need medical interventions, but a lot of time there's also things that the patient themselves can do. And so the patient application also includes a self-management library with recommendations relating to general health and healthy aging, cancer-specific issues, and treatment-specific issues. And based on the symptoms they report, they can access this information, and then there is also a full library that they can look at if they want to. And here you see an example. This one is in French, but it's also available in English and in Dutch of what the recommendations look like. As a final step of Work Package 1, we describe the care pathway step by step. So that anybody who is involved can understand where we are in the trajectory and what's expected of them and what comes next. Now, the research that we did was not just beneficial to the GERONTE project, but we believe it is useful for anybody who is dealing with older patients with comorbidity and cancer, and perhaps even in other primary illnesses as well, not just cancer. And that's why we made our research available for free in the Zenodo community. And this includes the 15 publications that were made on behalf of Work Package 1 in peer-reviewed journals. The results of Work Package 1 would not have been achieved without the help of all the healthcare professionals, the patients and their caregivers who shared their expertises, their experiences, and their thoughts with us. And so we want to thank all of them. And we believe that the GERONTE project shows that if we all work together, we really can improve the quality of life and the outcomes for older patients with multimorbidity and cancer. So let's continue to work together to make that possible. Thank you very much for your time.